soft and softer than we have thought until now, because we just have concentrate on many things. This will just on what guidelines say, officially say. When we see a man, infertile man, so we just want to see, just take history and performing physical examination and want to see semen analysis as the first step evaluation. Some guidelines put hormonal evaluation into the first step, but the AUA guidelines doesn't want to see hormonal evaluation in the first step, because we should know the semen analysis first, and then if the semen parameters are abnormal, then we want to see hormonal tests. And the second step evaluation will be some kind of radiological evaluation to differentiate from obstruction to non-obstruction, and finally some in abnormal semen parameters, which is less than 5 million per ml, to see genetic tests and some kind of biopsy. WHO just released a normal references values on semen parameters in 2021, as the ejaculate volume should be more than 1.4 ml, its permeability of more than 60 million per ml, and forward motility of more than 30%. Of course, we want to, as this step going up, and we want to see what every couple wants to conceive naturally. As the second step, hormonal evaluation is indicated if the sperm concentration is less than 5 million according to the AUA guidelines, and also if the sperm concentration is less than 5 to 10 million, and sperm hormonal evaluation would be necessary. As you can see here in this picture, sperm parameters, as sperm parameters decrease, and we see more deterioration in spermatogenesis. So we see low LH and gonadotropins and testosterone level in hypogonadotropic hypogonadism, and if we suspect obstruction, we see almost normal or close to normal level of gonadotropins. Genetic tests are indicated if the sperm parameters, the sperm concentration is less than 5 million, especially we see karyotype abnormalities in up to 15% of men with abnormal sperm parameters, and 6 to 8% of some kind of Y chromosome microdeletions like A, B, or C. And in patients with congenital absence of bilateral vas deferens, we want to see also in the patient and also their partners cystic fibrosis gene mutations. Just to read here what the official guidelines say, and with the level of evaluation, male infertility evaluation should include a medical, reproductive, and family history, assessment of lifestyle and behavioral risk factors, physical examination, semen analysis, and hormonal evaluation. As I told you, the same things. Also, genetic tests are indicated with the presence of sperm concentration of less than 5 million. Testicular volume can be measured with Prader oxidometer or using testicular ultrasound. Also, interestingly, the AUS German just talked about the diagnosis of radiologic imaging. As scrotal ultrasonography is also necessary not only for measurement of testicular volumes, for also detecting some kind of testicular lesion, because risk of testicular cancer. As Dr. Agarwal talked about, and also mentioned, high sperm oxidative stress has a detrimental impact on sperm quality, but there is a lack of validated assays to measure reactive oxygen species and oxidative stress in the everyday clinical practice. With 2B level of evidence and also high sperm DNA fragmentation index is associated with reduced pregnancy rates via natural conception or IUI, poor ART outcomes, and recurrent pregnancy loss, and also an unexplained infertility. Again, the chromosomal abnormalities are frequently found in men with severe oligospermia, which is less than 5 million sperm concentration with 2A level of evidence. Klinefelter syndrome is associated with non-obstructive azoospermia, hypogonadism, and general health problems, including metabolic, cardiovascular, and oncologic disease, again with 2A level of evidence. Y chromosome microdeletion is found in azoospermic men, especially in men with less than 1 million sperm concentration. Testicular sperm can be found in 2/3 of men with AZFG deletions. Again, scrotal ultrasonography would be useful in just diagnosing, also confirming the confirmation of diagnosis of varicocele, and also if the ejaculate volume is less than 1.4 million ml, transrectal ultrasonography will be necessary to indicate any ejaculatory duct pathologies. Here is recommendations, note the same things, and medical and reproductive feminist care should be taken with strong evaluation, and sperm DNA fragmentation test should be performed in the assessment of couples with recurrent pregnancy loss from natural conception and failure of ART, or men with unexplained infertility. With strong recommendation. It was weak recommendation in the last EAU guidelines, but it's now with strong recommendation. Hormonal evaluation should be started with testosterone and follicle stimulating hormone and LH. Prolactin is not necessary. What AUA and ASRM guidelines say, looking at here on the left side, any kind of ultrasonography is not necessary to diagnose or to confirm any pathologies. Clinicians just should recommend only renal ultrasound for patients with congenital absence of vas deferens. Here, and also the female age should be taken care of. If the female partner's age more than 35, and the ART should be considered for the couples or wife or partners more than 35 years. My last slide will be just the expert panel of GAF, which will be published or submitted to anywhere in the next months to diagnose, to differentiate obstruction from non-obstructive azoospermia. Again, taking history and performing physical examination and hormonal testing necessary. If the vas deferences are palpable, then congenital bilateral absence of vas deferens should be considered. If the physical examination is undefined and with palpable vas deferens, the ejaculate volume should be measured. If it is less than 1.4 ml, then transrectal ultrasonography and also hormonal tests are necessary to detect exact diagnosis. If the hormonal levels are too high or too low, actually abnormal, then genetic tests and including karyotype and Y chromosome microdeletions are necessary. So if they are in normal range, spermatogenetic defect should be considered as a part of diagnosis. Also testicular sperm retrieval can be considered. If all hormonal levels are too low, then pituitary MRI is necessary to diagnose hypogonadotrophic hypogonadism. Thank you very much.
Thank you very much, Professor Selahittin Cayan. Do you have any question?
Question, or we need to just
One.
take a discussion part without radiology assessment?
No, I've one
I
question.
learned a lot from you.
No, I have a practical question. So I agree. The guidelines would say, well, go ahead, make a clinic infertile man, come to you in the office and say, I'm infertile, I have a baby. You're arranging spermogram 1, spermogram 2. So it seems in practice they at least 3 visits he had it, and then according to the guidelines, you make a hormonal assessment. That's the EAU guidelines. So it seems
EAU guidelines.
EAU, yeah.
Yes, true.
So it seems for me always we have so lot
Right,
according to
true.
guidelines. I honestly would say I will not lose the time. So when he's complaining some kind of infertility, I say okay, we make a spermogram, we make a hormonal assessment immediately. So honestly, I'm doing this way, so I know the guidelines are differently, and honestly, I'm always for each one I'm checking not only testosterone, LH, everything, but I'm always including prolactin and other pathologies immediately, T3, T4. So what are you doing for your practice?
absolutely
I
right.
highly appreciate the clear talk, highly good talk. What are the guidelines? And now I'm addressing a difficult question for you. What are you doing?
Very nice point, but if we see only FSH and total testosterone level, so we can guess about LH and also prolactin. If the testosterone level is normal, so we don't expect any increase of level of prolactin. If we see FSH in normal levels, no matters if FSH level is low or high. If the FSH level is normal, doesn't matter related to LH level to see if the testosterone is also normal. According to
The question is,
clinicians,
how do you do it? How many appointments must a
you are
man
sure,
get
so
when coming to you? So that's the
in
question.
Europe and in Arabic countries and also in my country, it's very easy for patients to reach the clinicians. So we see
A lot of work.
a lot of times we can see,
Okay.
but in some countries it's not easy to see step by step. Also, some insurance companies don't cover the whole hormonal tests. So if you see, maybe they don't cover, that's why clinicians don't want to see LH or prolactin level. But it's not easy in some countries to see and to see again patients, right? But even if you see a patient who has 2 sperm analyses, which are not less than, the sperm concentration is less than 5 to 10 million. So you don't want to see hormonal levels again, right? You want to see
Basically,
gonadotropin
well,
levels
there was one
in men with more than 10 million
Yeah.
of concentrations.
Yeah, there was recently one update stating that below higher than 1 million, it's sensitive. Below the 5 million, it's not so sensitive. So it was a question. So honestly, yeah, I'm doing that. I'm honest because I have quite often a lot of compensated igonotropic mans, but they're compensated. So they're borderline high LH, normal testosterone. And the question is, are you looking on your testosterone or your free testosterone? Is the free testosterone calculated or measured? And do you look at it as a BG2? So I say, in my practice, yeah, I'm omitting. I'm not following the EU guidelines because I think that's not correct. Because I would lose time. In this follow-up, at least with schedules, at least 3 months is a minimum what you will lose it. For that reason, I say, well, make immediately the hormone test. Well, it's fine, then I know it, okay, I have an idea, at least we know I know what your FSH, and said, oh, okay, now I have to think about, but I admit, so the guidelines you pointed out are
Right.
so long, so delayed, my feeling, delayed.
Sure.
But maybe the patient in our hospital will not get immediately an appointment. They have to wait for 1 month, 2 months, something like that.
Another things and question would be if you want to see also estradiol levels
Yeah.
in men in men with obesity or
Yeah.
in obese men
Yeah, I'm doing, yeah.
at the
Honestly,
same time.
Yeah, at the same time.
So 5
At least
items.
estradiol.
Really?
SABG is standard. So the routine is protocol 1 to 3. So hormone assessment 1 to 3. Say there's nurses coming hormone assessment 1 to
It
3.
will be easy for us, but I'm not sure it will be cost effective or not.
I think it's more cost effective than the patient has to see by me.
Right. Your time more important than the patient's time.
Sorry.
Does it make sense at all to measure cortisol levels for the environmental causes?
No,
Yeah.
no,
Because it's fluctuating.
not
frequently, or-
necessary to
No.
see cortisol levels. So it doesn't have any effect on spermatogenesis. Only to see cortisol. If the gonadotropin levels, like including FSH are abnormal, maybe.
Then we have, at which time you measure the cortisol level? So the next question. You have a diurnal rhythm, so in the morning and the evening, so
Because
it's quite different.
yes, in testis, testosterone is produced in 95% of testes, only less than 5% in adrenals.
What about the measure of inhibin?
Inhibin B. Inhibin B, we don't routinely measure inhibin B, but there are some studies reporting inhibin B level is important in predicting sperm in azoospermic men, but they only remain as an experimental, so it doesn't make
It's not
any
important.
sense to see inhibin B
Possible.
level, right?
Possible.
It's correlated, positively correlated with FSH level.
Yes,
As
exactly.
FSH level
Yes,
increases, then inhibin B level
EV costs you 10 times more.
decreases.
It's
Right.
very expensive thing to be measured.
Also, it's very, very
Expensive.
expensive to measure.
What's about the exploration of gluconic obesity?
I didn't hear.
The gluconic exploration of this semen, like zinc,
Fructose.
fructose, catechin,
Biochemical.
Biochemical measurement of
yes,
semen. I have no idea. It's not routinely measured, but
It used to
maybe
be
not
about
well,
20, 30 years ago.
Well, there's one indication. For glucosidase and zinc is the one indication if you want to be sure about obstructive, non-obstructive. It's the only way. You need it. Elsewhere, you don't need it. It makes no sense.
Well,
There's really no sense of.
I agree with Gemma's clarifications because we must consider that a problem are the deadlines which we should follow. And the second problem is practical medicine. That is, if a couple arrives at my consultation, the male arrives with the wife drives the male, okay? And I need to obtain a rapid diagnosis and prescribe a rapid treatment. And also because at least one half of the couple arrive with the woman when she is not young, okay? And so we have to try to prescribe rapidly all the first examination. So semen analysis in my case plus functional test, okay? Hormonal evaluation, FSH, LH, testosterone, thyroid hormones, and estradiol, sometimes prolactin, not always sincerely, and for reasons of our research, 17 hydroxyprogesterone. Okay, and this is depending on the previous semen examination, we decide also for genetic examination. But we must be rapid because we cannot delay what the gynecologist will decide for this couple. This is the problem. Okay. About the biochemistry of semen, really, I used some details ago, but now I completely forget them because even in case of you have a suspected obstruction, generally your experience, okay, it's not so. There are some cases really doubtful, but generally by his clinical history, clinical examination, etc., you are oriented towards one kind of the diagnosis or the other.
Yeah, for a long time in the 80s or 90s, testing for fructose used to be suggested for azoospermia.
Right.
But
Also
I think most places are not doing these tests anymore. Also, there were several biochemical tests like I think glycerol, phosphorus, choline, and so many that we used to do maybe 40 years ago, but they are all now discarded. One comment I would like to make about the guideline, I think the guidelines are important for standardizing the assessment. It is important for many of you because you are young and not so much patients are there that you are examining. So I would like to convey this message that yes, when you reach to the level of Giovanni or Selahittin or Germer, maybe you can make some independent judgment when you have such amount of knowledge and understanding. But I will not change to start treating the guidelines, because they are there for a purpose to unify and provide you a very good idea for somebody who is really new to this or not seeing so many patients. To change things, I think you will make a lot of mistakes, and that may not be a very good thing to do. Right?
Yes, absolutely.
In case of question, yes, in case of
The rising testosterone in obese patients, is there any recommendation?
if the testosterone to estradiol ratio is less than 10, so the treatment will be an aromatase inhibitors, one of aromatase inhibitors. If it is borderline, which is 10 to 15, I'm not sure. If the ratio is more than 15, any treatment is not necessary. Even testosterone is low. Actually, aromatase inhibitors are not indicated in men with testosterone to estradiol ratio more than 15. That's studies say.
Of course, some lifestyle change.
If the sperm parameters are abnormal and in the presence of low testosterone, I think, like I said, Fabrizio mentioned, clomiphene or tamoxifen will be enough for those patients. If the couples don't want to IUI or any kind of assisted reproductive technology, if they want to conceive naturally, I think we should also learn many things from men with hypogonadotropic hypogonadism, because in azoospermic men with hypogonadotropic hypogonadism, we treat them. After the treatment, even they can conceive with sperm concentration of less than 1 million. So it means we have many things which are unknown. So we are saying, according to WHO, we are saying the sperm concentration should be more than 16 million. But they can conceive it in the presence of less than 1 million sperm concentration.
So what kind of
With morphology is normal.
You give them some sperm, but F-shape replacement, or H-shape replacement. What do you give in case of hypogonadism?
Just to replace gonadotropies, like with FSH or ACG or just in the combination of ACG and recombinant FSH for at least 6 months.
Then we will
On the contrary, we cannot find any sperm in man in hypogonadal man even under 1 year of treatment. We cannot find any sperm. And if the patient achieved to can have some sperm,